am Ira Kirschenbaum. I am the editor of the Journal of Orthopedic Experience and Innovation. Tonight, we have an amazing session, Beyond the Cuff, expanding the reach of biologic healing with EnFix. We have a great panel and some wonderful people in the audience as well, which we will call out mercilessly as the night goes on. All right, but at first, I'd like to start off by introducing the faculty. We'll start off with Dr. Setter. Why don't you just introduce yourself, Kevin, and we'll moving on from there.
Sure. Good evening, everybody. Kevin Setter, did my shoulder fellowship at Columbia, and since then I've been at Syracuse, New York, University of Orthopedics, which is an academic group. I'm presently the associate professor after doing a shoulder and elbow fellowship and then a hand and microvascular fellowship. It's a pleasure to be here.
That's excellent. And Dr. Howard?
Hi, everybody. Peter Howard. I'm in Palm Harbor, Florida, which is just outside Tampa to the Gulf side. I'm in private practice, sports guy, fellowship trained, and excited about to talk about Tetris tonight.
Excellent. Dr. Davis?
Good evening, everyone. So I'm in the Washington, D.C. area, and happy to be here. Thanks for having me again, Ira. So I do sports. I'm primarily doing shoulder, hip, and knee. And so again, excited to be here. So thanks for having me.
Excellent. Dr. Kartalian?
Thanks, Ira. Hello, everyone. George Kartalian, orthopedic surgeon specializing in lower extremity, knees, foot, and ankle, and in private practice, and have sort of a penchant for sports injuries of the foot and ankle. And so I'm happy to be here and talk about EnFix.
Excellent. And Dr. Papp?
Hey, Derek Papp. My training at Hopkins for med school and residency. Did my fellowship here in South Florida. I'm on the opposite coast, so I'm on the East Coast. I'm in Key Largo. I work with Baptist Health, South Florida. So thanks again for having me. Appreciate it.
That's excellent. So we're going to start with the presentations, as we often do. And I'm going to share my screen of the presentations. And Dr. Setter will be up first. And he's going to talk about what he talks about. Let's take it from there.
Sure. So I was asked to talk about my rationale for using Tetris and how I see this coming on in the future. So once I indicate someone for rotator cuff repair, you have the usual conversation, risks and possible benefits of surgery, what to expect preoperative, intraoperative, and postoperative. And then I always tell them, hey, listen, there are three things you need for a successful rotator cuff repair. One is you need to be physically able to get the tendon to the bone. Two is your muscle bellies need to be in good shape and not atrophied. And number three is you got to get the tendon to heal. Okay, doesn't heal, doesn't matter what you've just fixed. Okay, and then I get into the healing rates. And what's really shocking is if you guys take a step back and think, if you're going to talk to somebody about doing an ACL reconstruction, and you're going to tell them that there is a 20 to 60 to 70% chance that that's not going to heal, not too many people are going to sign up for an ACL reconstruction. Yet we do more rotator cuffs than there are ACL reconstructions, and we have a pretty high failure rate for this tendon. Go to the next slide, please.
Yep.
So then I go into the fact that, in the past 10, 15 years, we've really progressed with the biomechanics of rotator cuff repair. Anchor placement, suture versus tape, double row, single row, how to fix delaminated tears. And we've really come a long way with the biomechanics of fixing a rotator cuff. And probably in the next 10 to 15 years, now we're going to be looking at the biology of rotator cuff healing. And we're sort of in the baby infant stage of that. And, 15 years from now, we've been looking back and say, can you believe we were using a dead piece of patch on a piece of tendon that has no blood supply to try to get this thing to heal? So if we go to the next slide. So I had dinner with a pretty famous guy, not to mention names, down in Naples, Florida, who owns one of the big sports companies. And this was probably at 2017 or so. And we were talking about rotator cuff healing. And, it occurred to me that, right now it seems like we're treating the grass. Okay. And I know the studies on patches, and there is certainly some success with healing rates. But putting a patch is like treating the grass. And I saw back then that it would make more sense to treat the soil. And with Tetris, I think that's what we're starting to do is to treat the soil instead of the grass. The next slide. So I think other people are going to talk about the enthesis, but this is the four-phase transition, which we normally see with tendon inserted on bone, and we know that with rotator cuff repair, this is not what we see, but we certainly know that there's a biomechanical advantage to having that four-phase transition. Can we go to the next slide?
Whoops, sorry.
Yep. And again, this is going to be, people, I don't want to step on anybody's toes, but this is why I chose to start using Tetris, because it does provide the means to get enthesis healing. And I've been using this product for about 6-7 months. I began using it on patients who were non-heels, smokers, diabetics. And again, I have about 6-7 months experience with it. The early experience has been pretty good, but we don't know that there are a lot of rotator cuffs that don't heal that still do pretty well. So I've talked about doing I'm not funded by this company at all. I'm not on advisory board or anything like that. But I certainly would like to put forth a study to really look at the healing rates with ultrasound or MRI, and we're in the works of getting that set up. So that's the reason why I think this is a great product. It just makes a lot of sense.
Excellent. By the way, I want to mention if anyone has questions, just put them in the chat. We'll call on you to answer them, or if you're bold enough, feel like shouting out your questions. Peter, you're up.
Thanks, everybody. So I wanted to talk about my clinical experience. I think I've been using the product for about a year now, and I've had excellent experience with it. I'm a big patch guy before this came along, but I've seen failures of patches, and I think we all have. And I even have a picture of one that coming up here. But the basic science behind this is that I've always wanted some sort of like I want some gorilla glue that I can squirt in there between the rotator cuff and the bone. It's just glue it in there, and it'll have all sorts of biologic cool things in there, and it'll glue itself to the bone and repair itself. Well, you can't do that unless you've got a lot of money to burn, and that's a new drug. So this is really the next best thing that we have to be able to do that dream of some sort of like glue for tendon to bone that induces healing. This DBM that they turn into a fiber, so DBF, it really contains all those precursor molecules that tell the bone to heal to the tendon. And it's kind of like it's that thing we've been looking for, but we haven't really found it yet. And I think this is it. You can see some of these studies show that these DBM products really can recreate that enthesis. So this is an up-close picture of a real enthesis. And I know several of us have this picture, but this is the most important thing to get your rotator cuffs to heal to the bone. It's not just rotator cuffs, many other tendons to heal to the bone. It's the one we experience the most. It's so hard to talk to patients and say, hey, this past 6 months you've been doing PT. Guess what? It didn't heal. We got to go do it again. One of the interesting things I found when putting together this information is that the enthesis is really, it changes over time. And this is how I explain to patients how your rotator cuff happened. When you are born, it's not even the same as when you're 18. When you're 18, it's not how it is when you're 68. So it actually, the calcification, degradation, it changes over time. So if we're trying to get your 68-year-old enthesis turned back into an 18-year-old enthesis to get it to heal and be healthy, we have to understand how it works, and then we also have to understand how it breaks down. So I think this is really important. There we go. So we just talked about this a little bit. I won't go over it too much, but you got to get your four zones to reappear. And if you don't get your four zones of the enthesis, you're probably not going to get a good enthesis repair. Being here in Florida, we instead of grass, we have buildings that can get swept away by waves. And I really think of the enthesis and the Sharpie's fiber as like pilings that go down into the dirt. And unless you recreate those, you're not going to recreate a good tendon healing. So these are some images from an animal study. They put DBM between the tendon and the bone, and later came back and looked at it on the microscope. And now I'm an orthopedic surgeon. Microscopes and slides and all that kind of stuff. That's not what we do, but it's important for us to look, and we can actually see that on the left we have these Sharpie's fibers. You can see the different colors, the gradient, so you know the enthesis is there. No DBM on the right, you just get scar tissue. So scar tissue isn't going to be as strong as the natural enthesis. So here's some pictures from this is clinical application of this very concept. This is a open gluteal repair and glute max transfer. So you can see on the right there, you can see the bare trochanter, and you can actually see where I had previously went and did an endoscopic repair with a patch. No DBM or anything like that. Patient continued to hurt. That patch is on the wrong side. It is not on the enthesis side. The difference with using this product, as you can see, I'm inserting it into the trochanter there on the left, is that it actually is on the correct side, so we can actually get those Sharpie fibers to regrow, so our house doesn't get swept away when the hurricane comes. So your tendon remains intact when it sees strong forces. This is a case I did the other day, and I want to expand your thinking of this product outside of just the rotator cuff. I mean, it works awesome in rotator cuff. Don't get me wrong on that. But I do a lot of, I'm a bicep killer. Some people are, some people aren't, but I'm a bicep killer. But I like to tenodese some because I don't like to have the Popeye, and I don't like I like people to not even know that it was done and just to get the pain relief. So this is one that I did the other day, and this is how I do it is I actually make an enthesis between a tendon and the bone where there isn't actually one. Because we have those cell signaling DBM molecules, I'm actually taking this right here is my sutures that's going to the end of my bicep, and this is the bicipital groove. I actually take one of these devices and punch it and place it in the groove, and then lay the tendon on top so that the tendon can heal to the bone, creating enthesis. Otherwise, we're just getting scar tissue. And as we know, we can still get Popeye deformities in a bicep, tenodesis proximally. I'm not a big inlay guy because I'm afraid of breaking the humerus, but these are some of the ways that you can think about these new biologic products to have applications that nobody has really even thought of to use yet for better outcomes for our patients. And then, of course, there's traditional use in the rotator cuff, where you can see my medial row with a full thickness tear, and these go in just like anchors. These are all suture anchors that have been punched in, and you can see this nearly all the way through full thickness tear on the articular side. By the time it's debrided, and I put those suture anchors in there, I got what I call the intermediate row, which is the Tetris devices, the EnFix devices, right in the middle there, right at that footprint. We're going to have that bone to tendon healing. Sorry, went too fast. So, and this you can see, this is after the double row repair has been completed. And you can see on the right where you can see the device right there, right in the middle of the X box. And that's where all the magic has to take place. And I think that this product, it's on the correct side, therefore it's going to give us the correct healing. And if you really dive into all the DBMs and cell signaling molecules, I really think you'll see that in combination with the bone marrow. This is that tendon super glue that we've been waiting on.
That's awesome. That was great. Lonnie, you're up. Lonnie Davis.
Perfect. Thanks, Ira. And again, thanks for having me. And I'll probably emphasize some of the things that Dr. Howard just kind of mentioned there as well. One of the applications that I've been using this for is in the hip as well, specifically for the hip abductors, the as we call it, the rotator cuff of the hip, and kind of a similar concept in that region. And so, obviously the issue is that we're seeing a large percentage of these, a large number of these in our older patients, and a lot of us will see them in the office. Our total joint guys who have the long wait times will probably have a fair number of these folks sitting around waiting on their surgical docket, and so. But yeah, it's a pretty common scenario that we'll see. Certainly, some of the MRI studies in older patients will show a large percentage of these patients, especially in the women, who have these tears. And our radiologists have a challenge with diagnosing these. But as I said, we'll see a fair number of these, and we'll see that the repairs are starting to increase as we get better diagnostics. And I do think that we'll continue to see an increase in these repairs over time. All right. And then one of the challenges, as some of the other talks were highlighting, are the failure rates. Certainly, we have less data as we look at the hip abductor repairs, but we'll see some of the studies will show up to 35% failure rate. And similar to the rotator cuff, it's a tough situation because these patients have gone through quite a recovery process. And when we're looking at the hip, now they're in protected weight bearing. A lot of times these patients are on walkers and whatnot. So it does have a pretty significant impact in their mobility. And so obviously we're all looking for ways to improve these outcomes. And certainly the EnFix from a biological standpoint certainly gives us a lot of excitement here. But again, the failure rate there is, we look at the factors in terms of that increase the failure rate. Tendon retraction, obviously fatty infiltration is a big deal in the hip, similar to the rotator cuff. Same factors, poor bone quality, the tension on the repair, as well as anchor or suture failure. And when we look at the EnFix as a treatment option, really kind of addresses those last three options issues in terms of the biology and some of the mechanics in the area. So for me, this is an MRI representative standard partial tear or full thickness tear. Often if you treat these glute tears, oftentimes the superficial fibers will be intact. But so this is a common scenario that we'll see, and these patients will present with significant pain and loss of function. And so, but it can be a challenge to get this area to heal. And so the EnFix certainly gives us some good options. And this is my general approach, and it's similar to a rotator cuff. This is the footprint of the glute med and minimus. And so the implant certainly fits this application very well, similar to the greater tuberosity. And so in my hands, generally, this is a double row repair. I like to use small soft body anchors for my medial row, and that gives me plenty of real estate to add in the EnFix to maximize the amount of biology in that area. And then we'll do a traditional lateral row with either bio anchor or some type of screw-in anchor. So that's generally the construct. Now this is looking at this from an open standpoint, and this can be done arthroscopically as well. Certainly the EnFix lends itself to doing that. Obviously in the shoulder, that's the general application. But in this particular patient, this was an open procedure that was done. And this shows the implants in place. And again, from a function or a size standpoint, they tend to fit nicely just below the tendons along the footprint of both the minimus and the medius. And so this is sort of the final construct where we've done a double row repair. Now, one other area that I'm actually really interested in is in the distal biceps. I think this is another application, just as Peter was mentioning. I think as we look at using these implants, we'll find different applications that tend to fit it. I think the TAC-T implant is really well suited for the distal biceps area, and I've actually personally gone to using soft body anchors in this area, and those anchors are placed along at the proximal and distal aspects of the footprint. And I do think that the EnFix really fits into that type of application where we've gone away from the concept of drilling into the bicipital tuberosity and doing an intraosseous fixation, but really kind of reestablishing the normal anatomy and really the emphasis that's been damaged and utilizing our techniques to again to really try to reestablish the anatomy in a more traditional fashion. All right, good stuff. That's all I have for today. Thanks for having me again.
That's great. That is superb. I think we have Dr. Kartalian. You're up now. There you go. Gonna approve. Yeah, we go. All right. You may have to unmute yourself.
Okay, how's that?
Perfect.
Okay, so why Tetris EnFix? First thing is, every surgeon would really want to make sure that when they do a procedure, they want to optimize their outcome. And when you're doing a tendon back to the bone, anything we do to enhance that healing and optimize the outcome is what we're looking for. And we'd like it to not increase the difficulty of the case. And we also want it to have as few reactions as possible. Well, Tetris checks all the boxes. And I think now, as Kevin had mentioned, that any further advancement in the insertion techniques is kind of marginal benefit.
Oh, George, you're breaking up a little bit.
Specifically, anything that can promote natural state of healing with minimal trauma and minimal friction heal. And in this case, actual restoration of enthesis, it's ideal. It's quite simple to use. There's really zero learning curve. And we'll show you briefly a video of tendon case. It really has very little time, and it's quite simple. There's really not much typically do. And then, of course, the second generation of this fibrous demineralized bone matrix, or fiber, I guess, having that increased biological enhancement with, again, how they came up with a great process of just using water to get the structural stability of their implants, I think is another ideal part of why the EnFix. Let's see. So we're going to talk a little about insertional tendinopathy. The common thing that I've been using it for thus far. And obviously, it's mostly seen in elderly folks, but there's a degenerative case, but you tend to see it in younger people as well. You get a breakdown of the four-zone emphasis as it gets degenerative and swollen. You often try surgical treatments, but very often these do end up with surgery. When you're looking at the challenges of surgery, is again, it heals with scar tissue, as was stated previously, and not a true enthesis. And we worry about the extent of debridement that's necessary, and do you need to do a tendon transfer or some other biological enhancement? What about the sclerotic bone, and what's the biology of that? And in some papers, they say the revision rates can be up to 17%. Again, the fixation methods have improved, but we do need that biological improvement. So as we said previously, it's the second generation of this demineralized bone matrix, the fiber shape. They use minimal processing to get the implant shaped. It adds very little time.
Let me go to the next slide.
the controller for the maybe. I think I've got to go back to there's supposed to be a video there.
Okay, right here.
I can't see that control there.
I got it.
But while we're looking at that, you can see setting up for the double row. There we go. And here's that middle row fixation was that line. But here's let's see where we are. This is I guess we're kind of chopped up a little bit. But that's the implant going in, and you can just control the rotation with that easily as you pound that in. So use that middle line row as your guide to in between your double row. And then here you are just putting that implant in. And for the you're right there, it's anyway. And you're literally just add a couple of minutes to the procedure to get this improved biology. And at the end, so here's that middle row again where you're going to place the implant. This is very straightforward. That went a little quickly there, but just think about future considerations. Okay, so again, the middle row here, you got the distal row is going to come in later. Proximal row is set going through the tendons, and then we're going to insert that the EnFix across here to create that as Peter was hoping for. And so I really like using this. It gives me a lot more confidence as you're putting together the tendon after cleaning it all off and debriding it. And certainly future potential uses, looking at the ligament repairs and for a kidney procedure, just like that idea about the bicep. And to tend to be another indication, and possibly trying to figure out a good way to use it for the FDL and FHL transfers, probably a little bit like Peter does for the biceps tendon.
Oh, let's go back a slide. There we go.
Yeah, the take-home message of biological enhancement is necessary for the next step to improve our healing. EnFix, of course, does this with the synthesis formation, and the mineralized reaction is by having just a natural bone, demineralized bone matrix with just processed with water, and again, just virtually no learning curve and quite simple. So our plan is to gather more experience and expand the indications.
All right, I'm going to take it from here. That's the end of the slideshow. So I'm going to stop the talk here for a second. And Derek, you're
Yep.
up?
I'm up. Let me.
Okay. There's a lot of questions in the question thing, but we'll answer the questions after your talk, Derek, okay?
Sounds great. Let me know when you got. It looks like it's coming up. Let me
Yeah,
get
it is.
Let me get into slideshow format. There we go. All right, so I'll try to move so we can get to the questions. I don't have any financial disclosures. I'm not tied to the company. There's a lot of research showing that double row has biomechanical properties that you don't necessarily get with single row repair. But when you look at clinical outcomes, it's really not really that much difference unless you get into larger repairs. I think that the Tetris is an interesting implant. I think it potentially adds something there. Again, there's data that shows that if you use DBM, that it helps with healing at the enthesis again. And the idea here, like Dr. Setter was saying, again, we're creating roots in the grass, or I like the idea that this is it kind of acts as a wick. So you get access to all the marrow elements, and then this thing just basically wicks those out and helps with recreation of the enthesis. So again, some animal studies show that there's greater resemblance to the native enthesis after using the product, and that there actually may be better healing faster using it. Let's see. I am stuck. There we go. Oops, great. So the construct is this. Nothing crazy there. The idea is to put we'll go straight to the video. So The idea is you create a trough here. So this is taking a burr. You come in there, I change sides so I get a little bit better access. Touch up the bone again here. The idea is to create an area for the tendon to heal. Just doing that by itself does open up the bone for healing. Here I'm going to skip through this, but I put a bunch of stitches into the cuff. So stitch, stitch, stitch. I can see that I can mobilize it up to where it bumps into the bone there. Clean it up a little bit to make it easier to see. And then again, it doesn't take long to put in the implant. It takes, really 5 minutes at most. Just basically tap, tap, tap where you want it. I like to put it on the edge. You can see the bone marrow elements there just kind of oozing out of the bone, which I think is great. I think it tells you what's really going on there, and what helps the implant work. Again, you just put the implant into the bone. It doesn't take a lot. The inserter device is a little bit long. So you'll see here, you just got to twist, twist, twist. And it just keeps coming out eventually. The implant expands a little bit once it's been in the joint for a little, so that it helps you take it out. But again, see how long that is? It's kind of neat. And then I do kind of a knotless SCOI row thing. This one doesn't have too many sutures in it, but I try to get, 2 stitches per anchor if possible. There are other, I usually use Smith and Nephew, but Stryker makes something where you can put up to, you can put more than 3 limbs if you want, but that's another way to go. So again, this is just fixing the cuff. You can see that it attaches, there's bone to the leading edge of the tendon, and then it attaches to the tetras underneath it. And then just kind of cleaning this up. I'll scoot ahead. This is what it looks like at the end. So again, if you can see my cursor, this is bone, leading edge is touching there, and then the tetras is underneath it. This is looking from the side. I've been doing this for, I don't know, I'm similar to Dr. Setter in that it's probably been my 7th or 8th month using it. I don't have real data, and I'd love to do a real study, but so far the patients have been happy, and I've been happy with the product.
Oh, thank you. This is great. This is the second one of these we've touched on with Tetris, and I don't have an indication for it, but I'm so excited about it. I sort of want to go for surgery and see how it works on me. Yeah, I don't know. I'm trying to figure out an indication, Yeah.
We're always looking for volunteers, Ira.
Yeah, I'm good.
When you do a biopsy too, you volunteer for that? And
I got that. No problem. With both knees and a hip done, I'm fine. So we had Bill Curtis. You had a couple of questions. Bill, you want to unmute yourself and ask your questions? First about single row, double row, and then about some of the finances. Are you available, Bill?
Yeah, just unmuting there. So my question, which Dr. Papp kind of touched on, is everybody's looking at how many pennies for the procedure. Is this possibly a superior method versus, with the EnFix versus a traditional double row, which is obviously more implants, etc. Does anybody have thoughts on that, or is there still strong feeling that the mechanical advantages of double row still should be utilized?
I mean, I'm biased. I've never really fully drank the Kool-Aid on the double row. I'm more single row whenever I can. I do think if you create a nice biologic environment like they teach you out, I'm not a SCOE grad, but like they teach you out there, if you create a good healing environment, I think that increases the chance that it's going to heal. And so I like the potential here with this product.
And I wonder if there's this faster remodeling, incorporation, again, healing at the site versus the globus scar tissue.
I think that there's some data, I don't have the paper in front of me, but I think there's some data that shows that using DBM does increase or makes the that process faster. I don't know if any of the other panelists have seen that during the course of this.
Well, I have anecdotal experience where it does seem to have a little faster recovery, but it's just in the few patients I've done. But I do think in terms of the double row, single row, I have a lot more confidence with that secure fixation. I think it does allow that earlier mobilization. I know for the Achilles, because it's weight bearing, you have to have that really strong fixation.
All right. I think Georgia, you got a little internet issue. We'll
I
oh, you got it. Yeah, you're back.
Okay. Sorry if you missed all that. I just said that basically I do prefer the double row with the Achilles because they are weight bearing and like to get the mobilization. I just feel the confidence of that secure fixation. I think part of that is you get that enhanced biology. In my anecdotal experience of the several patients I've done, they do seem to heal up very quickly uh, and a little bit faster than the ones that without the tetris in there. But it is just anecdotal without a study right now.
Peter, you answered a question in the chat. I just want you to expand on that question. When you would use EnFix with or without patches. So, what's your thoughts on that?
So Florida is a pretty favorable environment for a lot of the reimbursement on these devices, both patches and the EnFix device. So I have the luxury of being able to use whatever I want, especially on my more commercial cases. But I work with one of the patch companies, and so I've been using a lot of patches for a long time, and they definitely the data I think is there that says that they help. But like I mentioned, they don't, it's on the wrong side. I think it does something. So when in a payer situation where say it's a Medicare case, say it's a limited reimbursement on certain things case, if I have to choose between the two, I'm choosing the NFix because it just makes more sense. It's on the correct side for healing. And I, I'm probably, we fixed rotator cuffs for a long time without patches. We know that they can heal without a patch. And I think putting it on the enthesis side just makes more sense. Now, you know, double row, single row, I'm more of a double row guy. Under low tension. And, everybody's got their own opinion. As long as it heals, people will be good. But I think that fix the cuff in the way that you normally fix it and you get good results. By adding this step that takes a minute, 2 minutes to your procedure, it can potentially really enhance your healing. Versus if you're not an experienced patch guy or you don't want to spend the 15 minutes to put a patch in there, or the patch costs orders of magnitude more than this device. I think this device makes sense when you're juggling your decision in the OR between cost and patient outcomes. It's kind of an easy default to say lower cost, easier insertion, quicker. And when your OR time costs $1,700 an hour, 2 minutes versus 15, there's some costs associated there. So I think those are important things to think about when choosing products.
Yeah, Kevin Setter here. I got to agree. I think you made some really good points there. I think you fixed the rotator cuff the way you do it as best you can, and that you're getting good results with. And this is sort of in addition to that to just increase that healing potential. And if I have a choice or if I had a money issue and it was a rotator cuff that I can fix that I wanted to augment, it would be this over a patch all day long. The only ones that I'd consider a patch, perhaps more than say something like this, would be if I have a Sagaya, a symptomatic Sagaya 3 with a real thinned out rotator cuff, that I'm going to go in there and redo it just to thicken that cuff up a bit. But other than that, if I had to choose one for a cost reason, it would be this. It just makes a lot more sense to me.
Excellent. Excellent. Let's talk about another application in total shoulder anatomic total shoulder arthroplasty. And this possibly is directed to Dr. Setter and Dr. Davis, do total shoulders. What about in a role for subscapularis repairs? What, what do you think about that?
Yeah, I think same thing. If especially if I do peels, unless I have a real significant or negative passive external rotation preoperatively. We all know rates of subscap non-heal maybe 12, 13%. So I definitely would see a potential role for it in increasing the subscap failure. I think I give a whole presentation on are we doing too many reverses? I think the answer is absolutely yes, we are doing too many reverses. But obviously with your anatomic total shoulder arthroplasty, that subscap healing is critical, and I definitely see a role for that. Certainly, if it can be proven that you can get a tendon that has a poorer blood supply to heal at a higher rate than without.
Yeah, I actually agree with Kevin on that in terms of using it in that application as well. I think it's similar to our traditional cuff repair and even with the reverse. I mean, I think a lot of the guys are doing subscap repairs on their reverses as well. And some of those outcomes are certainly improving. So yeah, in similar scenario, I mean, obviously getting in the anatomic is a bit more of a high stakes scenario with the subscap. But and so anything we can do to improve that is obviously helpful for us.
I want to just jump in there and echo that comment that the last, I think, one or two revisions of a total to reverse that I had to do was due to subscap failure. And I'm the guilty party putting in too many reverses. But I did a total shoulder the other day, and the ability to put this device in that footprint versus multiple anchors or however you do it through the stem or whatever, you can just lay it right there, and you have some bone to put it in, and you're not going into the canal where you're going to hit the stem or something like that. So, when subscap failures cause a whole reoperation, a 1 minute little device to put in there, increase your rate of healing just makes sense.
It's excellent. What are some of the use case scenarios we possibly have not talked about um, that are on your minds about? I have some in my mind, but I'm just curious what you guys think, whether it's foot and ankle, whether it's other sports injuries. What do you guys think?
I mean, I think that there are indications if, like, let's say a quad tendon repair, patellar tendon repair, it's easy to. They're one of the we didn't talk about, but they do have an implant that actually is designed for to take like an all suture implant and put it right through the middle of it. So if you want to do some sort of construct with that, and I'm just using the quad and the patellar tendon as an example, but you could. I do a similar technique when it comes to my triceps. I've used it in the triceps before. You put the tetris in the middle, and then I have two all suture anchors on the side, and then you tie up, and then I'll come around and reinforce it with knotless anchors on the side of the olecranon too. So it's there are other places you could use it.
Great. What about gluteal repair? Not gluteal, sorry. Proximal hamstring repairs. Same idea, right?
I would think so.
Scopic hamstring repairs. And while I have not had the opportunity to use this device in that setting yet, it goes in exactly how your anchors do. If you do an endoscopic hamstring or an open one, it's just like putting an anchor in. It makes total sense. I use it for tennis elbow. I'm a takedown repair guy. And then, basically anywhere the tendon attaches to the bone is where you want an enthesis, you can use it.
Great. I'm amazed at some of the total joint guys in capsule repairs or bringing up the posterior capsule onto the bone, onto the trochanter, have not thought about this, or maybe they have. We just haven't invited them to a topic session. So maybe that's yet another indication in posterior approaches to the hip. So we'll talk about that. One other question I'd like to ask is about innovation in general. If this came out first, before all these massive numbers of metal anchors and everything else, and before the original patch that came out, um, would we have these other advances, or would this be now the gold standard if this came out first, let's say about 8 years ago? What do you guys think about that?
Yeah, I think it all bears out on what the study showed. What's going to be the true healing rate? Even though with specifically rotator cuffs, I had a great talk with uh, Joe Ionati, pretty smart guy, talking about looking at correlations between outcomes and actual healing. We do know that obviously strength is associated with rotator cuff healing, but when a patient has pain post-op and they're asking for MRIs, and the MRI will always come back. That's why I never get an MRI. Never say never unless they have an injury. Get an MRI before 4 to 6 months because it looks like a bomb went off in your shoulder at that time. And they're all read as partial tears, and they panic and they think they have a big problem. But if the studies bear out that this does decrease uh, the rate of non-heal, then I think yeah, this would be the gold standard. Again, you're treating the soil and not the grass with this.
Great.
Yeah, and I
Uh,
think that, we're looking at, a couple different factors here. I mean, obviously there's the biology and the stability. I mean, there's the emphasis and the tendon. And so the patches obviously are addressing the tendon issue. And we've kind of used those a fair amount to really try to improve our healing rates. But I do think that they're not necessarily mutually exclusive. But I would say that this would have a bit more applicability in terms of being, all rotator cuff tears likely have an emphasis issue, but not all have a tendon issue. And so I think we'll find that we can use this a bit more broadly, and we'll save our patches for those that actually need a patch.
any more comments on that topic, or?
Yeah, I'll jump in again. I think that if this came out before, say, the Regeniten or the BioBrace or any of those kinds of things, I don't think that you would have seen the market penetration that those patches have because of the ease of use of this product and its scientific backing. I think you would have a lot of people saying, well, I'm already treating what needs to be treated. Why would I put a patch on? Now, maybe there are some circumstances for bridging of repair or really thin tendon. And so we'd still be using patches. I mean, all these products have their role, but I do think that we wouldn't have this patchomania that we have. I think that it would be almost like a niche product, the patches would be.
Excellent. So as I like to say, this always is the fastest hour in orthopedics. Probably you guys could get 3 rotator cuffs done in this hour, but that's a separate issue. I'd like the faculty to summarize and give us some final points of what we have, and we'll start with Dr. Papp. Just give us a little bit of sort of an overview, maybe where the future is going, or just some final thoughts for tonight.
No, I think that hopefully this is gives us a future option for tendon healing to bone. I mean, like they say, it's the future is really the emphasis. So I'll leave off to somebody else.
All right, Dr. Kartalian.
I think we're at a very exciting point. I think that Tetris and EnFix are quote unquote something, and I think that all these different applications that we're talking about tonight, I think are great. I really like using it. I'm very confident when I use it, and I think that for those out there who haven't tried it, it's very simple to learn, and I think you'll enjoy the satisfaction and the confidence you get of seeing that wicking and how the biological healing comes about.
Awesome. Dr. Davis.
Yeah, no, I think it's great. I mean, I think that, just from the talks, it looks like most of us are kind of early adopters to this. And, as surgeons and as we offer these things to our patients, we always do that, with a great deal of responsibility. And so I think it's great to hear how different surgeons are utilizing this in their practice. And, being an early adopter on this type of technology, I feel pretty, excited because I do think that, hearing how other folks are using it, it does give me some different thoughts on how to integrate it into my practice as well. So I think it's good stuff.
Excellent. Dr. Howard.
Well, I just want to say that my use of this product over the past year or so has been, it's just simple, it's easy. And then after digging into the science, it just makes sense. So if this is something that you're looking at trying, it's very easy to integrate into your practice. And overall, we're all here to make people better. We're all here to make our patients better. And the worst thing is revisions. And if this gives you that chance, I'd say give it a try.
Excellent. And Dr. Setter, you want to bring us home for tonight?
Sure. I think going last, I can echo what everybody else said. I will say when I first started using this, I think they missed the boat a little bit on the slogan when they say it's all about the emphasis. I told them you should be saying it. The emphasis should be on the emphasis. And the applications for this, if this thing pans out to increase healing rate, is going to only expand. I forget who mentioned it, pardon me, but usually no one in my group likes to handle tennis elbow. Now I'm thinking, wait a minute, this might be a great thing for I only operate on patients selectively with symptoms for a year plus. But these are tough cases where patients get better 80% of the time, but you use this and you get good tendon healing and not that tendinotic healing. This is something that can change a lot of things. So I would say it's you're doing this for a while. It's hard to get excited about something, but this is something that is exciting.
That's excellent. I want to make some final comments. I want to thank the entire panel for coming tonight and all the participants and people who asked questions. I'd like to have a special thank you for Tetris for being a sponsor for tonight and a sponsor of a lot of the activities that the journal, JOEI, the journal, does. And one day I'll figure out exactly what it does, but right now, we're sharing a lot of good information in the community that I don't think would have a voice otherwise. So I want to thank everybody for tonight and say good night.